Hello. Quick environmental check. This is Allie. Okay, so my patient will be down here today. This is my setup. Nothing on the walls over here. Nothing down here. This was our original setup, but we just haven't moved it back yet. Nothing. My dog, wondering why I haven't fed him dinner yet. Okie dokie. Hi, my name is Rachel Kroc. I'm a PA student at Nova Orlando University, and today I'll be performing a respiratory, cardiovascular, and abdomen exam on you. Okay, so I'm going to step away, wash my hands quickly. I'll be right back. All right, my patient appears healthy and in no apparent distress. Traditionally, I would ask my patient to remove her shirt. However, today we will be keeping the shirt on for today's exam purposes. All right, so I am first going to start by inspecting my patient. I'm going to have you turn a little bit. Thanks. So I'm inspecting my patient. Turn more. This way? No, I get this off here. Yeah. I'm inspecting my patient for symmetry of anatomy, for contour, for anterior to posterior diameter, which should be 2 to 1. I'm inspecting for skin lesions, any superficial veins, any lesions, and the lips for central cyanosis, and the fingers for peripheral cyanosis. Okay, I'm going to take my 2 thumbs here. I'm going to place them at my patient's T10 vertebrae, and I'm going to have you breathe in and out for me. Great. Chest expands symmetrically. I'm going to have you hug yourself for me. I'm going to go ahead and palpate all up this posterior chest wall. There are no deformities, step-offs, crepitus, masses, or tenderness noted. Okay, I'm going to go ahead and check for tactile fremitus. So, whenever you feel my hands touch these 4 areas on your back, I want you to say the words 99. Okay?
99, 99, 99, 99.
Great. Tactile fremitus is equal in all fields. Now I'm going to percuss for diaphragm excursion. So I'm going to find your resting diaphragm wall. Great. Now I want you to breathe in for me and hold at the top of that inspiration. Great. I'm marking this spot as along with my starting point. Now you can breathe out, and at the end of that, hold. Great. Now I have those 2 points. You can breathe and relax. I'm going to go ahead and measure this. Diaphragmatic excursion is normal at 4 centimeters. I'm going to go ahead and palpate these 7 lung fields. I'm going to do it in a ladder formation. 1. We're palpating for lung resonance. 3. 4. 5. 6. 7. Okay, there's no dullness to percussion. Great, now I'm going to tap right here. Any tenderness?
No.
There's no CVA tenderness noted bilaterally. Great. Now with the diaphragm of my stethoscope, I'm going to listen to some of our breath sounds here. Right, so every time my stethoscope touches your back, I'd like you to breathe in and out of your open mouth. Okay, take a big deep breath in and a big deep breath out. Are you lightheaded at all?
No.
There are no adventitious breath sounds heard. Now, I'll spin you around. I'm gonna put my gloves on and I'm going to palpate around those armpits for the axillary lymph nodes. Okay, put your arm up here. I'm gonna go ahead and place my hand in that armpit. I'm palpating the anterior, posterior, those central, and those lateral nodes. Great. There is no lymphadenopathy noted in the anterior, posterior, lateral, or central nodes. Now I'm going to ask my patient to lay down in our supine position. I'm going to go ahead and I'm going to start just palpating this chest wall. Okay. There are no masses, crepitus, or tenderness noted in the anterior chest wall, or the anterior chest. Now, I'm going to go ahead and check for tactile fremitus. Again, every time you feel my hands hit your chest, this time in 3 areas, I'm going to have you say the words 99.
99, 99, 99.
Great. Tactile fremitus is equal in all fields. Great. Now I'm going to percuss in 6 of our lung areas. Again, we're percussing for resonance. I'm going to skip number 3. And go down. 4. 4. 5. 5. No, 6. Kind of on her flank. Up here. And 6. Great. So there's no dullness to percussion. Now, I will go ahead and I am going to listen to my patient. Okay. And I'm going to start by listening with the bell of my stethoscope at her apices. And again, you're going to breathe in and out with an open mouth. Still have the bell. Okay, I'm going to skip number 3. Now change my diaphragm. We're starting at 4 now. Breathe in and out. Big breath. Number 5. Number 5, 6. Number 6. There are no adventitious breath sounds heard. Okay? And now, if there were adventitious breath sounds heard, I would have my patient sit up for me and might as well just. And I would perform a special test, the egophony test. So every time you feel my stethoscope touch your back, I'd like you to say the phrase E. Great. Testing there with my diaphragm, I heard E. It would have been a positive test if I heard ah instead of the sound E. Okay, now moving on, we're going to do our cardiovascular exam. I'm going to begin. Just going to listen to these carotid arteries with the bell of my stethoscope. Okay, I'd like you to go ahead and hold your breath. There are no carotid bruits noted. Now, since I have the bell on my stethoscope already, I'll go ahead and listen to our valves. So the aortic valve, the pulmonic valve, the Erb's point. I'm going to displace your breast for the tricuspid valve, now the mitral valve. Great. Now with the diaphragm, I'm going to listen to the mitral valve, the tricuspid valve, our Erb's point, our pulmonary, and our aortic valve. Okay, with my diaphragm over the Erb's point, I'm going to have you take a big inspiration in and breathe out. The physiological split of S2 is noted. All right, now with my still over the diaphragm, lean over, breathe out and hold your breath. Okay, there's no murmur of aortic regurgitation. Okay, still with my diaphragm over the Erb's point, I'm going to have you go ahead. I want you to breathe all the way out and bear down. Great. There is no murmur with Valsalva. Okay, now moving on to the supine position of my cardiovascular exam. I'm going to go ahead, be on my patient's right side again. And I'm going to start by placing my ruler at my patient's sternal notch right here. I have this straight up. I'm going to ask you to move your head to the left. And I am looking here for her pulsation of her jugular vein. Okay, I'm going to measure this. Great. So the jugular venous pulsation is at 3 centimeters above the sternal angle with my patient at 30 degrees supine. Okay, now with my light here, I'm going to go ahead and shine it on the side, take a good look at the abdomen. I'm inspecting for any precordial heaves, and I'm also looking for the point of maximal impulse. I'm going to go ahead and palpate my valvular areas, the ball of my hand. There are no heaves, lifts, or thrills, and the point of maximal impulse is non-displaced. Great. Now I'm going to go ahead and again listen to those valvular areas with my patient lying supine. I'm going to start by listening with the diaphragm of my stethoscope down at my patient's mitral valve. I'm going to displace your breast. So the mitral valve, the tricuspid valve, our Erb's point, the pulmonic valve, and the aortic valve. Okay, now changing around with my bell. I'm going to go backwards, do it. Aortic, the pulmonic valve, our Erb's point, displace the breast, tricuspid, and our pulmonic valve. Our mitral valve. Great. Now with my bell still placed on the mitral valve, I'm going to ask you to turn left for me. And I'm still listening to the mitral valve with the bell. All right, there are no gallops heard or noted. Gallops would be S3 or S4 sounds. All right, and the rate and rhythm is regular without murmurs, gallops, or rubs. Great. So now I'm going to take a look at my patient's peripheral pulses. So go ahead. I'm going to bilaterally check I'm going to unilaterally check her carotid pulses. I don't want to obstruct both at the same time. Okay, and now I'm going to bilaterally pulsate her brachialis, her radialis. Okay, her popliteals, her dorsalis pedis, and those posterior tibialis. Great. Pulses are equal and full bilaterally. Okay. I'm also checking our toes here and the fingers. There's no peripheral cyanosis, no clubbing, and the capillary refill is less than 2 seconds. And taking a look at my patient's legs here. I'm palpating and inspecting for edema, any hair distribution changes, skin lesions, skin conditions. I'm checking with the back of my hands for any changes in temperature. And I'm also looking for viscosities. Great. Moving on, I'm going to have these pillows removed. I'm going to have you laying flat for the remainder of the exam. And I'd like you to bring your knees bent. Just rest your legs like that. Great. So, you're fine. All right, to begin our abdominal exam, I'm also going to just lift your shirt up a little bit, just so we can expose our abdomen. So I'm inspecting the abdomen. And the abdomen is flat and non-distended. I'm going to listen to the abdomen with the diaphragm of my stethoscope. I'm listening over the right upper quadrant, the left upper quadrant, the right lower quadrant, or the left lower quadrant, and the right lower quadrant. I'm also going to listen to the epigastric area, the umbilicus area, and the hypogastric area. Great. So bowel sounds are present. Now with the bell of my stethoscope, I'm going to go ahead and I'm going to place it over the abdominal aorta. I'm going to check the renal arteries, and the iliac arteries. Okay, there are no bruits noted. Traditionally, in an exam, I at this point would also do the same on the femoral arteries, and I would also pulsate those and check there for the inguinal lymph nodes. However, today we will not be doing that today. If it was a good exam, I would find that the pulses of the femoral arteries are equal and bilateral, and they're equal and full bilaterally, and they, there's no inguinal adenopathy. Okay. Now, moving on, I'm going to percuss, okay? So I'm going to go ahead and I'm going to percuss, just do a general percussion over the right upper quadrant, the left upper quadrant, the left lower quadrant, and the right lower quadrant, the epigastric. And here, all of these areas I'm percussing for tympani and dullness. So our umbilicus, and this is my hypogastric. Okay? Now I'm going to percuss down our mid-clavicular line, and I'm going to percuss the liver. So the liver is 7 centimeters in the mid-clavicular line. Okay, now I'm moving over here. It's going to percuss. Find that anterior axillary line and that lower intercostal. Percuss down here for our spleen. Move back a bit. Go ahead and breathe in for me. Great. There's no splenomegaly noted with tympani. Okay. So now I'm going to lightly palpate, starting in the right upper quadrant, the the left upper quadrant, the left lower quadrant, the right lower quadrant, the epigastric region, the umbilicus region, and our hypogastric region. Okay, so there's no tenderness, guarding, masses, or rigidity to light percussion or light palpation. Now I'm going to do it a little deeper, okay? The left lower quadrant, the right lower quadrant, epigastric region, umbilicus, and the hypogastric. Okay, there's no tenderness, guarding, masses, or rigidity noted with or to deep palpation. And I'm also going to check for any rebound tenderness. So I'm going to go ahead and push in deep here in your right lower quadrant. Any tenderness?
No.
No rebound tenderness noted. I'm also going to test that in the right upper quadrant. Tenderness?
No.
No rebound tenderness noted. Okay? Now I'm going to just place here and look at my aorta pulsation in width. So the aorta is 2 centimeters in width, and there are no lateral expansions of the pulsations. Great. So now I am going to go ahead and just palpate around the liver, and I'm going to use a hook method. So I'm going to hook my fingers, again, the midclavicular line. I'm feeling around here, and I want you to take a deep breath in. Okay. So the liver is, you can breathe out, the liver is non-palpable and non-tender. I'm going to go ahead, and now I want you to lay on your right side for me. And I'm going to palpate for the spleen. Okay. The spleen is non-tender and non-palpable. Right. Now, also in a traditional exam at this time, I would go ahead and do a rectal, genital, and hernia exam on my patient. I don't think she really wants me to do that today. I don't think he back there wants to see any of that today, although he doesn't have any eyes. But we're going to go ahead and leave that out of the exam today. Lastly, I'm going to go ahead and perform 6 special tests on my patient. I'm going to have you turn back around. I'm going to be on the right side of you. Okay, I'm going to expose your abdomen exam again. Okay, the first test I'm going to perform is the Murphy's test. I'm going to press really hard in this right upper quadrant and breathe in for me. Okay, any tenderness? So this is a negative Murphy's test. A positive Murphy's test would show that there is tenderness when she breathed in and I pushed down, and that would be a sign of cholecystectomy. Okay, now I'm going to do the iliopsoas test. So I'd like you to have your legs straight for me. You can do this leg straight so they can see it. I'm going to go ahead, place my hand on your right thigh. I want you to try and lift your thigh up and resist me pushing it down. Is there any pain noted?
No.
This is a negative iliopsoas test. A positive test would note pain and would indicate peritonitis due to ABI. Next, I'm going to do the arbitrator test. So I'm going to flex the hip. Okay, I'm going to go ahead. I'm going to internally rotate the hip. Is there any pain there?
No.
No pain?
Mm-mm.
Okay. This is a negative arbitrator test. A positive test would include pain with that movement and would indicate peritonitis due to ABI as well. Okay, now with the next test, our heel tap test, I'm going to go ahead And okay, I'm gonna go ahead, lift your heel up, keep your knee flat or locked. I'm gonna tap, tap. Any pain? Any pain? This is a negative test. A positive test would accompany pain and would indicate peritonitis due to API. Okay, with my patient laying down, I'm going to do the Rothstein's test. So with this test, I'm going to push really hard down in my patient's left lower quadrant. Any pain?
No.
Okay. This is a negative sign test. A positive test, my patient would have had pain radiating in her right lower quadrant when pressing down very hard in her left. And this would indicate appendicitis. Lastly, I'm going to do a shifting dullness test. I'm going to go ahead, I'm going to percuss around the upper abdomen. And I'm percussing for tympany and dullness. Okay, now shift to your side for me, please. I'm gonna also do the same areas. Okay, this is a negative test. There is no shifting or dullness noted. There's no shifting of tympany or dullness. So a positive test would note that shifting, which would indicate that there's some fluid in my patient's abdomen, which would indicate further an ascites. Also, one more exam I forgot to do quickly is just your abdominal reflex exam. So I'm going to lightly just drag this. Great. There is no abdominal reflex noted. All right, that completes my pulmonary cardiovascular and abdomen exam today. I hope you have a great one. Thanks for watching.